Hi, everybody. Welcome to this edition of the CHP Spotlight interview series. Today, I am so excited because I'm joined by my good friend, Dr. Nathan Yokel, and what you can see behind him with regenerative orthopedic and sports medicine, better known in the DMV here as Rossum. Dr. Yokel, he specializes in sports medicine and implements regenerative treatment with his patients, which is really unique. Pairs it with traditional procedures as well, and rehabilitation to help his patients get back to the activities that they love. I'm going to let him speak more about this as we go on today. But Dr. Yokel, thanks for joining us.
Happy to be here. Thanks, Zach.
Yeah, absolutely, absolutely. So first, to kick things off, I'd love for people to get a chance to know a little bit about you. You have a really interesting story. I know we've gotten coffee and chatted about this, but I'm always fascinated by it. I'd love to hear from you. How'd you get started as a doctor, and more specifically, what inspired you to transition from your background in public health into more, I don't want to call it traditional medicine, but into medicine, and then how it even blended into becoming a specialist in regards to sports medicine and regenerative treatments?
Sure. Well, I'll just tell you the whole story, I guess, for a little condensed version. Growing up as a kid, I went through traditional kid stuff. I wanted to be a Ninja Turtle. I wanted to be a gangster. I wanted to be a professional sports player, but none of those things were really in the cards. And my mom is a physical therapist in the area, and she works in Wheaton. She's a pediatric physical therapist, and she used to bring me to the office with her, and always liked seeing what she did and like that kind of interactions. In high school, I shadowed a few different doctors. One of them being a doctor. She worked with the physiatrist, which I am, a physical medicine rehabilitation doctor. I've also injured myself in orthopedic ways over the years, and so gotten to see the system from that side of things. In high school, I used to volunteer at this mobile medical clinic, which was kind of like a free clinic over in the Montgomery County area, and kind of doing blood pressures and patient histories. I could already tell it was something I like to do. So I pretty much knew I was on some kind of path towards medicine. In college, I had a job at Anne Arundel Medical Center, which is an emergency room, being a scribe there. So you're following emergency room doctors around. You're seeing everything they're seeing. You're writing stuff down for them. You're taking notes for them. It's pretty eye-opening and enjoyable, and I knew that it was something I was interested in. And so then I went on to medical school, and in medical school, you try lots of different things. And it was clear to me that although I like emergency medicine, that I don't want to do that for 50 years. I wanted to have an office and long-term relationship with my patients. And so I started getting more into the idea of some kind of sports medicine and orthopedics or something like that. During medical school, I had a beautiful son, and he was down here in Maryland. I was up in Philadelphia in medical school. And so I was kind of going back and forth a lot. And it kind of crystallized the idea between that and several broken fingers and sprayed fingers I've had over the years with football and car accidents, that perhaps traditional orthopedics or surgery was not the route I wanted. I wanted to spend some time with my kid when he was growing up, and you lose a lot of that as a resident in the orthopedic world, especially as a single father at the time. And I wanted to do something where it would be a little bit different and there would be procedurally based, but I could do it if I get arthritis in my hands years and years from now. And so then I got into the idea of physiatry, or non-operative orthopedics, or physical medicine rehabilitation. Had that spark earlier in life with my mom. I took some time off of medical school when my son was born, and came back down to Maryland and did a public health and business program at Johns Hopkins University. And I was very into the issue of health disparities and kind of the public health issues we have in the country. I spent a lot of time trying to develop this program, Take Charge of Your Health Today, to try to empower people to use free and low-cost clinics to improve preventative medicine, healthy lifestyles, things like that. Take charge of your health early so you don't have toes amputated, going to the ER later in life. But I was very frustrated by the bureaucracy, trying to get something off the ground. You talk to a lot of different professionals, and everybody's, oh, this is a great idea, we should do this, and then nothing. And then it's get caught up in the bureaucracy. And so I kind of decided maybe I would come back to that later in life as a professional with something to do, and kind of jump right to the top with my ideas. And so I'm back to medicine. And so I went to residency program. I did my residency in National Rehab Georgetown Hospital. One of the doctors I was working with there, he was a first year attending doctor. I was a first year resident. So these are the guys we learned from. They used to have a continuity clinic. This is where we see people coming in with their general orthopedic problems, knee pain, back pain, whatever. They would see a resident like me. We would go present to the attending doctors, tell them we thought was going on. This is a plan. Then we go do the plan with them. And there would be different doctors that would staff this clinic. Or some doctors, more of the older school, be like, oh, it hurts there. We're going to put some cortisone in there. This is the soft spot. This is where we do it. This other doctor I was working with was very into the idea of ultrasound, which I'd used a little bit in my internship, who was interested in, as well as this idea of regenerative medicine. And he's like, look, this is the nerve. It's stuck on the rib. I'm going to put the needle next to the nerve and lift it up. Pay attention because you're doing the next one. And I was like, yes, this is the kind of stuff I want to be into. This is, to me, the wave of the future, marrying technology with some of the new treatment modalities that are coming out. And so then I kind of got down this path. Me and one of my other co-residents who was interested, we would spend all the time ultrasounding each other. We're on call, ultrasounding each other's shoulders and wrists or whatever, and just getting really into and trained on that. And then I left that residency, and rather than going to join a doctor I was talking about, I decided I wanted to take a job at a different practice that took Medicare and Medicaid and was going to do some spine injections, and did training on that. And I was doing spine injections and helping people, but it's a very different model. You had to see 30, 35 patients a day sometimes. It's not enough time to speak with them and talk about what's going on in these other ways and really make that empathetic connection. And it's tough trying to help people get off of pain medications into other roads. Sometimes they want to, sometimes they don't. It was very taxing, and it wasn't necessarily feeling like I was practicing medicine in the way I felt like it should be, having had these different experiences. So I left that group and I joined Rosum. At that point, my mentor was one of the founders of this group. I started working with them, and it's been wonderful. And now, here we are 9-10 years later, and I'm one of the partners of the group, helping to kind of spread our message, which is that there's other things out there than traditional orthopedics and surgery. There's a huge treatment gap between cortisone and physical therapy, and now we're doing a definitive surgery. And in the middle, that's where we live. And so doing different treatments like this, using ultrasound, using different procedures to loosen tension or create healing or to calm things down or to calm down a nerve or to release scar tissue, all that can be done in the office with a minimal recovery. This has been very satisfying to me. And I think also just having the time to spend with patients to say, look, yes, you have some knee pain, but there is some weakness in here. This is going on here. You're going to need to do these exercises. You should go work with somebody like Zach. If you've already worked with somebody like Zach and it's not getting better, now let's talk about these other options.
Gotcha. Well, first of all, I appreciate that background there. It's really fascinating to hear just how you got to where you are, and then also really cool to see sort of the mission and the impact you're trying to make at Rosum with a lot of your patients. I love that it's trying to find solutions that maybe aren't always surgery. And surgery, again, has its time and place, of course, like everything does. But hey, maybe there needs to be more choices ideally. And now you mentioned a lot of the benefits and some of the things that you do at Rosum, some examples of regenerative treatment. What I'd love to hear, and I know a lot of people listening to this are probably curious about, is hearing a little more about really not just in general what regenerative medicine is, but how you use, because you mentioned the diagnostic ultrasound, how what exactly is it? Because I know it's not the typical ultrasound you'll see in the old PT clinics of yesteryear. It's usually something you guys use it a little different.
Yeah,
so how do you,
sure.
So what's the benefit of that?
Let's talk about ultrasound first, and then we'll layer in how we're using with some of these regenerative medicine. So ultrasound's been around for many, many years, going back to sonar, looking for boats and stuff. They used to use it actually to scan sides of boats to look for defects, to know when they need to kind of hammer them out. When it first came out in the physical therapy world in the 20s, it was billed as a cure-all, a new cure-all for everything, using ultrasound on every body part. So it did go that way. And then it started breaking more and more into other areas of medicine. Obviously, everybody thinks about OBGYN, where they ultrasound your baby, cardiology, using ultrasound to look at echocardiograms, and rheumatology started using it. And then over the years, it used to be you need a room the size of a kitchen to have an ultrasound. And then it became a cabinet, and then it became a stand. And now you can have one on your iPhone if you want, although maybe it's not the best quality. But those ultrasounds, the decrease in size, the decrease in cost, and the increase in accessibility has really become a wonderful clinical tool that probably should be more used. This should be the stethoscope of a musculoskeletal doctor. We see what's going on, we want to see that, and want to see what's happening. Some of the benefits are that, one, there's not much radiation. This is sound waves rather than things that are going to cause any kind of damage. It gives us real-time information. I can see what's going on. I can see things move. I can talk to that patient and show the patient what's going on. We can give them an answer that day. It's going to be in knee pain, shoulder pain. I can see that rotator cuff tear. We can choose to do a treatment if we want, versus the more traditional measure. Well, we see an X-ray. No, there's not a fracture. Now we need an MRI. We have to get the MRI approved from insurance. You have to get scheduled. It's going to take a week or two. Now we have 2 weeks where we don't really know what's going on, or we think we might know what's going on, but it's affecting the trajectory of your care. And so if we can find things with ultrasound, it makes sense in a lot of ways. And so that's kind of how ultrasound became more used in medicine. And in the orthopedic world, it's really doctors doing musculoskeletal medicine or physiatrists that have done a lot of it. Sports medicine doctors do a lot of it. Rheumatologists are starting to, neurologists a little bit, and even some orthopedics are starting to do this. The problem is there's not enough people doing ultrasound for it to be a ubiquitous tool. There's a lot of operator error. You can have somebody like me that's dedicated my life to learning it, because somebody else that took one weekend courses and now is doing ultrasounds and billing for them and paying for them and injecting people with them. And so there's a big gradient. And anytime there's a gradient in quality control, that's going to degrade trust for people from different things. There've been studies looking at a full ultrasound report of your shoulder is 98% sensitive and specific for rotator cuff tears. Not that far off from an MRI, and we're also getting functional information. We just can't see some deeper things. I can't see in a disc. I can't see what's going on 100% with the labrum. I can see the periphery of a meniscus in a knee, but I can't see that inner edge. And so there are certainly cases where with MRI is better. We kind of utilize them both in this practice as needed. And so as ultrasound becomes more and more prevalent, we need more doctors to do it. You could go through my same entire resident as a physical medicine, non-operative sports medicine doctor and never touch an ultrasound. You could do a training program like mine where it's prevalent, you're going to use it all the time. And so you have a big variety of different doctors coming out of school and different training. It's unfair to ask a surgeon who's going to be an expert of all these different surgical issues to also be an expert of ultrasound and non-operative care. And yet they have been. And when you twist your ankle, you go see an ankle surgeon, and you don't go see a cardiologist or cardiothoracic surgeon when you have a little chest pain. And so the things are flipped upside down. Really, in this world where you have an injury or a sprain, you should see somebody like you or your family doctor. They say, okay, this is either getting better or not with physical therapy. We're going to have you see somebody like Dr. Yokel. I'm going to see and say, well, this is what I think is going on. If it's a surgical issue, I'm going to get the appropriate imaging. I'm going to send you to a surgeon to address it. If it's not a surgical issue, well, let's try and fix it without that. And so that should be the way that things flow, but instead it's gone a different direction. And I think things are changing a little bit. And I think I have a great relationship with a lot of surgeons in the area. We work together very well. And the surgeons that we work with, they really appreciate what we do because it's helping them focus on what they need to do. And it's providing a different set of options for their patients. When I'm giving informed consent for a procedure, I'm telling them you can have surgery, you can have this, you can have that, you can do therapy, or you could do these injections. But it's not really broken through. We're having surgery saying, oh, you could do this, you could do that. And so we need to continue to educate people there. So with ultrasound being more and more prevalent, we need to continue to encourage the use of it. And we need to encourage groups to fund research on the efficacy and the appropriate use of it and continue to train up groups of doctors to be able to do this, to kind of spread this. Now, if we want to talk about regenerative medicine or reparative medicine, and I think there's a debate about should it be called regenerative medicine? Should it be called reparative medicine? We're not growing ears on mice. We're stimulating healing. And so to be clear, that's the goal. We're trying to stimulate healing. It's not magic. And so when you have an injury, your body goes through the phase of healing. It gets inflamed and sore for a couple of days or swollen, goes through the fast or proliferative phase of healing for 3 to 4 weeks where things are healing at a rapid rate, goes through the slow remodeling phase of healing for 6 to 12 months where it's healing, but it's a little bit slower. Then it's kind of stagnant. Like we did. We're just going to use other things around it. And it's just kind of holding steady. It's not actively healing. Traditional orthopedic medicine has been a lot about calming down inflammation, using cortisone, using Advil, using Aleve. You calm down the inflammation, you're going to feel better. But it's not healing anything. If anything, is muting that healing process sometimes. And now while it's calmed down, if you can fix it with therapy, get stronger around it, maybe that's all you need. But a lot of times it's not going to give you lasting relief. And they've showed that repeated cortisone injections over time can almost have a negative negatory effect on things. So it's not a good long-term plan, but it's been used that way sometimes. More and more, it's not being used that way. It's antiquated now to go into orthopedics. They're like, we'll just do cortisone every 3 months, and then we're going to do this. They're not practicing that way anymore. The good ones are not. And so I don't want to make it that this is they're doing it this way. Everybody realizes that this is not the best solution. So when we think about regenerative medicine, this is actually going the other direction. We want to stimulate inflammation. We want to spark your body to go back through that proliferative or the active phase of healing, but in a targeted way. So if you have an old injury of a ligament in your back and it's causing some weakness and it's causing some pain, and I've been dealing with this back for 20 years, how's this going to help? Well, it will, because it's going to tell your body to get back to work. It goes through the phase of healing, gets inflamed and sore a little bit. You have to rest it for a couple of days for most people. Calms down and feels like it's doing nothing from your perception of it, but under the surface, it's going through this proliferative or faster phase of healing. Then kind of 3 to 6, 3 to 8, 3 to 12 weeks later, we start seeing this improvement. But the improvement you're feeling is not necessarily that the pain is just dead in, that things are a little healing and more stable. And then somebody like you can take and say, okay, we couldn't get that gluteal muscle activating, but now we can. Now we can really kind of take it and run with it. And so that has become such a wonderful tool to help stimulate healing and stabilize things. And a lot of times I'm not just only treating that injury. I'm treating the area of weakness that led to that injury as a unit to get more lasting, long-term functional relief. The types of regenerative treatments range from prolotherapy or proliferative therapy. This is using for us a sugar or dextrose solution. There's other things you can use to stimulate inflammation and healing. This is going back, way back to the idea of the ancient Greeks injecting blood in different areas to stimulate healing. It has been around and used in rheumatology and in the jaw since the 50s, 60s, 70s. C. Everett Koop, the former Surgeon General in the 1980s, was both a physician that used prolotherapy and a patient that was treated with it and advocated for it. But it never really broke through to the mainstream or was more popularized. And then in the 90s, early 2000s, as the platelet-rich plasma treatment started becoming more popular, originally with horses and horse racing and then breaking into people, this idea of taking blood, centrifuging it or spinning it to isolate out the different weighted layers, throwing away the red blood cells that deal in delivering oxygen, centrifuging it again, throwing away the other factors not involved in healing, and then injecting those direct healing factors into the area where you need to heal. And it's going to get inflamed and sore, but then it's going to go through this passive healing. On from that, now there are treatments using your adipose, using your bone marrow. These are two groups of cells that are rich in stem or signaling cells that signal a stronger healing reaction. And in the case of adipose, it also your body's using it almost as a scaffolding to build on as raw materials. And with the advent of those treatments, I think there's also been an increased popularization in prolotherapy. Used to be with traditional prolotherapy treatments, they're doing 6 to 12 treatments, 2 to 3 weeks apart, peppering all these different surface anatomy areas. Now with the ultrasound, I'm not doing all that. I'm finding the injury and I'm putting it right in there. We're seeing that improvement. We're seeing improvement, wonderful. We're not seeing improvement, but we're confident we're hitting the right areas because sometimes I'm using an anesthetic or a numbing medication at the same time. So we're not only causing the inflammatory healing response, we're also saying, yeah, that must be the spot because look at you now, you're stronger, you don't have pain. If that's not coming along, we may consider doing the plasma treatments. And for other more advanced conditions or condition no response, we think about the advanced cellular treatments. And there's now a lot of research and data out there showing that grade 1 and 2, mild and moderate arthritis, do great with plasma treatments. Grade 3 and 4, they do better with stem cell-based treatments or adipose or bone marrow-based treatments. And that's what the literature is showing. Doesn't mean that you have to do one or the other. You can make a case the same way I want to prevent diabetes by eating right. Should we be preventing arthritis by certainly exercise and being stronger, or doing some of these treatments when the symptoms are mild and not waiting for them to be severe? These are all things that I think are going to come out over the coming years. However, despite these huge increases in the amount of studies and research behind them, we have not seen a major breakthrough in insurances accepting them as a covered procedure. Some groups are starting. Police and fire, workmen's comp are starting to pay for that, but most groups are not. I think they will in time because these treatments are becoming more and more accepted as effective. Orthopedists are starting to do them because they've seen the research behind them or done their own research. And so it's a wonderful time where I think we're going to see more and more of it coming out and becoming more of the popular mainstream treatment options.
Wow, well, first off, that was super helpful in so many ways. And I love it's so obvious just how up to date you all are with all the new research he's coming out, because everything's always evolving so quickly. And what I love is that, and then to summarize things for a lot of the rehab audience who's watching this, is what's really cool and we've seen with our patients that I've worked with Ross and worked with Dr. Yokel and his colleagues is that, right, the ultrasound has been fantastic because it almost takes us from more of this sort of shotgun approach and allows us to be like almost like a sniper, like very pinpoint where we can actually like find specifically the area we want to go after. And then we can target that with whatever, any one of the treatment methods that you just outlined so effectively. And as you can see, there's a very step-by-step thought process of, okay, we go from with this to this to this. And so there's, it's not just like you go and there's only one option to help you, and which I think is also
Absolutely.
really
And I
as
mean,
well.
to be clear, the regenerative treatments we're talking about, most of those are not covered by insurance, but there is a ton of procedures that we do that are covered by insurance and utilize ultrasound. We use ultrasound to target and inject joints, tendons with anything. We will use it to guide our needle to find areas of scar tissue where something is not moving because it's stuck, and use fluid and the needle itself to scrape and release that area. That's something that's covered by insurance and only a day or two of downtime. We'll do injections where we can find a nerve that is trapped by scar tissue or fibrosis, put a layer of fluid around it and expand it around it, or hydrodissect that tendon from the tissue around it so that now the nerve has an increased signal. It can decrease the pain or weakness that it's causing. And all these treatments, the diagnostic part, all that is covered by insurance. So I certainly don't want to dissuade anyone from coming to see us thinking, well, there's nothing for me there and none of it is covered. 90% of what we do is covered by insurance. And most of my patients get better without needing some of this regenerative treatment, but a good amount of them do. And the more we're doing it, I know people are seeking me out for this now. I think something else unique about our practice is that we are all non-operative specialists. We're sports medicine, we are physiatry like me, and we're all pretty much leaders in our field. We go to conferences, we teach at conferences, we continue to powwow with the other people like us around the country to help push it forward. We're trying to create a database of research and education to be able to better show why these treatments need to be covered. We're sharing ideas with each other. This is working for me. This is working for you. This is what the research shows, kind of a meeting in the minds. Then we come back and teach it to some of our younger doctors and teach it to each other. And so it's ever evolving. It's a very healthy field where there's a lot of innovation right now. And it's a very exciting time.
It is exciting. And I think, and right, what's really cool is you're always pushing the envelope to try to find new ways of implementing these things that you're doing to just to help your patients. I know the patients that we've sent there have had, they can see that, they appreciate you could sort of see that energy, and that's a lot of times what people want and need in many cases. And so that sort of leads me. Oh, and by the way, one thing I also want to mention, I want to touch on that you mentioned, is that a lot of these treatments, one of the things I always have loved about it is it really appreciates the physiology of what our body's capable of. It is trying to facilitate the body to do its thing, as you mentioned, to facilitate, in layman's terms, a healing response in many ways. Because I know you mentioned, there's some procedures that facilitate inflammation, and oftentimes we're trained to think that's such a bad thing.
Yeah.
Right, because we anti-inflammatories, anti-inflammation, and so inflammation, though, it's there. It's something that's
It
supposed to
serves a
happen.
purpose, right? I mean, there's times where it's too much, right? People with rheumatoid arthritis or autoimmune inflammatory response, their inflammation is too high and it needs to be calmed down. When you have an injury and things are really swollen and inflamed, you can make a case, let it run its course. You can make a case, well, if it's so swollen and inflamed, you're walking funny and causing other problems, maybe you do need to calm it down there. But the main thing is that you don't necessarily need to calm it down in a chronic process. When you're trying to calm down inflammation, but it's not new or overgrown, you're not really helping anything. And to be able to modulate that inflammation and kind of tell your body to get back to work is a very powerful process. And then sometimes these other things, loosening tension here and there, it's not like that's creating inflammation. It's just allowing your body to be in a more natural position where it can finish healing itself, where it can settle in and be stable. Because a lot of times we don't see a big injury, we see a little injury, but keep getting irritated because we can't use things the right way.
I love that. I wanted to highlight that because I know that's something we often talk to our patients about, is just appreciating how resilient our body is, and just almost a lot of times we can serve as a way to respect that and almost use the things that we're capable of. That's fantastic. And a lot of these tools do a great job of that. And again, like we mentioned, there's a time and place for surgery as well. So not to say like with what we do as a rehab standpoint, and that Dr. Yokel, you do, we're going to be able to fix every single person. But I think there's a lot of like you mentioned, a lot of times there's a lot of things we can do before seeing the most invasive option. And speaking of that, you alluded to this earlier, but I wanted to ask, how, if I'm a patient and I'm listening to this, how do I differentiate who the right person to go see for my injury is? When should I see somebody like yourself versus, oh shoot, I need to go to my orthopedist?
Sure. Well, I mean, I think part of what most people don't realize is that physical therapists these days are doctors of physical therapy, and they've been forced to go through do this. You could make a debate, is that because higher education wants more money? That's another issue I'm not going to get into. But you're very well trained to triage any injury, right? If you have an injury and it's not like the bone is sticking out of your arm and you can bear weight on it, most patients should start with a physical therapist. Now, you might go to urgent care or something like that, where they're doing an x-ray or something and saying, filed with the orthopedist, do whatever, but they're ruling out something acute and dangerous, right? We know it's not acute and dangerous. A physical therapist is well trained to really handle most little aches and sprains. When you meet them on the first time, most therapists have a sense of either, okay, this is something we can rehab, or there's something else going on there, and they may send you on to me. If I see you and I think what's going on is something that may require surgery, I'm going to order the appropriate imaging, an MRI or whatever, then I'm going to send you to the surgeon. So by the time you get to them, it's not like, okay, go to MRI, come back in a month. No, you have all the information they need. You know what the non-surgical options are for me. They're looking at the information, telling you, yeah, I think you need surgery. Or they don't have to say you need regenerative medicine. If they say anything else but surgery, okay, it's on. We're going to try and figure out what we can do. And that's kind of how I would approach it. I think the other thing you would think about is fractures, right? If we think it's a fracture, I'd rather you go see an orthopedist. They have x-rays in the clinic. They have the bracing and materials and the casting materials that I don't keep in my clinic. And so fractures, acute fractures, displaced fractures should go to an orthopedist. Fracture that's been going on for months and is not healing should come to me. Some of these injections can help stimulate healing in fractures that are not healing appropriately, but fracture management and unstable areas, these are the things that generally need surgery. But you don't always know that going in, and so I'm happy to see anybody. And then I think the other thing is, somebody, a physiatrist, a non-operative doctor, should really be the second opinion for any patient considering surgery. I think that, a lot of medicine has been, particularly we are spoiled here. We're in a metropolitan area with a lot of options. Many areas in the country got one orthopedist for 200 miles. You go and he tells you what to do. You're like, okay, I guess we're doing it. It's not the case here. And so you can find different options and different opinions to help you make that informed decision. And unless it's something where this is detached, it needs to be reattached, or this is so unstable and clunking around and getting caught up, it needs to be fixated. Those are the things that absolutely need surgery. Most other stuff is a gray area. And I think that's where you want to know your options.
I love that perspective. The gray is huge, right? The gray is huge. Understanding that there's a reason we say we practice medicine, right? It's because, there's an art to it too, as well. And right, and that's why I love, that integrative approach that you guys take. And so look, Dr. Yokel, you've been super generous with your time. And, as you can tell, my dog in the background here is barking away. But with that being said, before we finish up, our patients that we've sent to Ross, we've sent so many at this point, they always have great experiences, whether they see you, whether they see your colleagues. For anybody watching this, what's the best way for them to find you?
Yeah, sure. Well, our website, rosm.org, you can find us there. There's a lot of information about the treatments we do. There's some testimonials of patients that have had these experiences. There's links to research articles about why we're doing these treatments and what's effective or not. So that's a good resource. On the website, there's a button you can click to send an email to Rochelle. That's her name. She's the one that reads the emails. And she will call you and say, okay, where do you live? What do you need to see? And she'll get you in with somebody. Now, it might be that you can't see me for 4 to 6 weeks, but you should absolutely see whatever doctor they try and get you in with. These are great fellowship trained specialized doctors that do wonderful care. Usually they'll say, look, you can see Dr. Yokel 4 to 6 weeks, but you can see the other guy right now. Take both appointments, see them. They might solve your problem before they get to me. Otherwise, I'm happy to help. And as you know, if it's something specific that you need to get someone in, they want me to see, I'm always going to make the time. I have a physician assistant, Alex Schultz, who is wonderful. He's a wonderful practitioner as well. A lot of times I'll put patients on his schedule and just go check him and see them and make the plan. And so there's a lot of ways, but I think the best way would be the website. There's information on the website. There's phone numbers and stuff like that. And I would also encourage some of your patients to go check out our YouTube page. We've made a lot of different videos explaining what we do or some of our treatment approaches to different conditions, you may be able to find what's going on with you there and kind of get a different overview of it.
Gotcha. That's huge. I'm going to check out the YouTube page now that I know about it. And
This video is probably going to be up there in a bit.
perfect. No, I love it. Well, this has been super helpful. I'm going to, like I said, I can't wait to get the feedback from our audience on what they see about this. Like I mentioned, to anybody watching this, we send a lot of people over to Rossum. They all have great experiences. They have locations throughout the DMV as well. And I've met nearly all their providers at this point. I would have no reservations about who you see. So,
and I would say to the national community, there are people like me in your city. And so, although we're available for telehealth consults from anywhere to kind of give you a plan, certainly searching out ultrasound, regenerative medicine, physiatry, you're going to find them in most major cities. And I just encourage everybody to kind of know all your options before you make definitive medical decisions.
Love it, Dr. Yokel. Well, I know it's getting late for you all, so I appreciate your time, and thank you for doing this today.
Anytime.